give them up here. You are going to come up here.
She made me get up here. Okay. Would you like to round everyone up?
I will run up.
Yes.
Okay, ladies and gentlemen, can I have your attention? It's actually a fun time. Listen to me, everybody. There's still too much talking. It's not on? It's not on?
It's on.
It's on. Okay, I'll get closer. Okay, guys, ladies, we're going to have some fun, okay? We've had a great time for intellectualizing. Now we're going to just see if we can win a prize. Now, each of you, I want you to know, have a ticket that you might not have known. A red ticket, which is in the back of your label. So if you will take out your ticket, we have two wonderful ladies behind me who are going to work with me to see how you are doing with the numbers. So you can't hear the numbers if you talk too much now, so listen very carefully. I'm going to have Tatinga Knox, who will be calling out the numbers, and then Catherine Flaherty will be coming. Whoever gets is going to get a gift from her, but you have to come up here and you have to tell us who you are. So now, Tatinga, start with the raffle.
Thank you, Marion. Nope, sure is not. Okay, it got quiet. You guys want to know who wins first? The first number is 822-5201. 822-5201. Yay, a winner! This young lady here.
Come on, Jennifer, tell us who you are.
Hello, I am Jennifer Chang, and I'm from UT Southwestern, and I am a data scientist as a part of the CIC team. Thank you.
The second number is 822-5251. 822-5251. No one. Nope. 822-5194. Jenny, is that you really? Let me check your ticket. 822-25. No.
Who has it?
It was Jenny. 822-5176. We have a winner.
Tell us who you are.
Just had to get Catherine's picture. Yes, 822-5274. 822-5224. 822-5157. Where are all these people at? 822-5104. 822-5254. This is starting. Okay, let's do it. 822-5137. 822-5137. 37. 822-5205. Okay. 822-5154. A winner, okay. And that concludes the raffle. Thank you.
Woohoo, it's afternoon. So it's a happy time. So everybody's full. Yeah, but please don't sleep, okay? This is really hot topic. You need to pay attention. So it's the best practices challenge for AI security. It's really hard. So I'm very privileged and pleased to introduce our wonderful keynote speaker, the Lisa Bages. Lisa Bages is distinguished cybersecurity leader with over 2 decades of experience in IT and more than 15 years dedicated to information security, particularly within healthcare sector. As the Chief Information Security Officer for the University of Nebraska Medical Center and Nebraska Medicine since 2018, Lisa has been at the forefront protecting critical health information systems and driving strategic security initiatives. Her expertise spans governance, risk management, compliance, and security architecture, while she also oversees a comprehensive security program that includes malware defense, digital forensics, and enterprise-wide cybersecurity operations. Lisa holds multiple industry certifications, including CISSP, HCISPP, and CHISL. I don't know what they are. And then she brings both technical depth and strategic vision to her role. She earns BS in computer science and master's science in cybersecurity, underscoring her commitment to continuous learning and leadership in evolving threat landscape. As a passionate advocate for building resilient healthcare systems, Lisa brings a wealth of insight, practical experience, and thought leadership to every stage as she steps on. So please join me in giving a warm welcome and then the big round of applause for our keynote speaker. Thank you.
So then I just use this?
Yes.
Okay. All right, thank you for that welcome. Hi, everybody. As she said, my name is Lisa Bezos, and I'm going to talk about AI security and what we're doing about it, what the trends are, and everything around it, because it is such at the forefront of everything we've been talking about, as I even looked at all the posters. So, as she said, my name is Lisa Bezos. I am from the University of Nebraska, University of Nebraska Medical Center, and Nebraska Medicine. So we are the teaching hospital and the academic center for the University of Nebraska as a whole. So I get the privilege of doing academic research and clinical all under one umbrella, which is actually, in my mind, makes it easier than having it separated into two. But as we start on this AI journey, and I call it a journey because journeys don't have a start or an end, and they're always ever evolving, and that's the way I feel about this AI journey we're on. AI applications in healthcare, they vary from academic purposes to research to clinical to precision medicine to all of these things. And we're going to talk about the journey of that throughout this presentation. But really it's going to go down into the best practices for how do we actually secure this to make sure that all of the data we're using is trustworthy, the results we're using is trustworthy. It goes down to really just trustworthy is the main theme here, is how do we make sure that our research has integrity, our patient outcomes are the right ones, et cetera, all from this AI journey. So academic healthcare institutions sit at a very interesting intersection between clinical excellence, cutting edge research, and education. And AI is rapidly becoming a foundational tool across all three of these pillars. But it offers transformational potential if used correctly, but it also introduces way more security and ethical challenges along the way. So as it's revolutionizing diagnostics, this is not a new thing. We've been using AI in imaging for years before it was even considered AI. I kind of joke with the team as whether or not it's just an algorithm or something like that versus real AI, but that's neither here nor there. But anyway, we've been using it in MRIs, CTs, everything for a long time. Now it's just starting to get more and more pervasive into the other areas where pathology and genomics is really getting into it now too. And then the clinical decision support systems that are trying to help take the data from one system, analyze it across with another system, and then try to come up with a faster way that we can get results. But really, the gist of it is that the goal of all of this inside clinical medicine is really to get faster results, like I said. It's faster results to the patient, faster results to the clinician, so they can make different decisions at a more timely manner, so that we can improve more lives. But when you get into the research world, it gets a little bit more not prescriptive, and the sky's the limit. But we have to really, really, really be careful about what types of data sets we're analyzing, how we're doing it, and what data sets we're using, where we're sending the data to be analyzed, et cetera. Because natural language processing, they automate literature reviews, they can do all sorts of those types of things for us, and those are pretty benign and safe. But it's really when you get into the EHR data that really the threats and the worrisome starts. One of the things we're dabbling in on this right now is actually having virtual assistants inside the patient rooms that are tracking basically the heat map of our patients right now to see whether or not we predict a fall based upon their movements and stuff. We have it in one unit right now, and we're looking at rolling it out to another unit, because the one unit we put it on, they're not falling. So we're going to test it in a different unit, but it's actually very interesting because it's going to then it's going to model the way the patients are moving on a regular basis, and then they can know if it gets out of the way that they flip around in bed and everything. So really, truly, it's going to, we think it's a patient safety revolutionary tool that we're going to use. And so, but how does it all work with inside of the healthcare environment? So like I said, we can do virtual care. You can have your watch and your wearables. This can tell me, with the new Apple Watch that's coming out in, I think, a couple weeks here, it's going to have even more sensors in it that are going to be able to, I don't know what just happened, that are going to be able to even predict more future things with you, especially in the cardiac world. And so how do you get those things to then run into your phone, which then goes into your chart, which then notifies your doctor? All of those things are all of that has to be AI behind the scenes that is listening for all of that to recognize regular noise versus a key critical thing. And then really, truly, how do you get customized plans out of all of this, with all of this data and all of this modeling? It's going to really enhance the patient experience. But with all of this, like I said, every time you try to do a new model or a new analysis, you introduce new threats and you introduce new vectors, is what we call it in the cybersecurity world. If you think about it, if you take your data set and you put it into a model to chunk something, and you have very specific PHI in there that is very specific to a certain type of, especially rare diseases, that can be reverse engineered, that's a privacy breach. How are we making sure that all the models that we're using are safe, contained, and I always like to call it a protective moat around it, because all of it's really about protecting the data and protecting the patient. And then when you get into the research world, it's also about preserving your integrity as researchers, because it has to be replicatable. You have to be able to prove everything that you've done. And if you don't know what's happening inside of that model and you don't understand the algorithms behind that, then you're not going to have the scientific integrity for your research. And so then what are we going to do? So when you get into academic healthcare, there's many, many, many use cases that are going to come along with associated challenges. So this next section, we're going to talk about how these intersect with security, privacy, and ethical concerns, which is going to set the stage for the deeper dive into the specific risks and mitigation strategies of what the meat of this presentation is about. But really, when you get into clinical decision support using AI that analyzes the complex medical data in real time, it's scoring, the real-time risk scoring identifies patients at risk for critical conditions like sepsis, predictive analysis, forecasting disease progression, enabling proactive care, those types of things. We've been doing that for a while. It's just going to get smarter and faster now. But when it gets into like the population health management segments, that's really where it's going to get, I think, going to get even more interesting, because you're going to be able to pull more and more data sets, not just from your EMR, you're going to be able to pull it from your consortium of EMRs. And if you're a member of some of the larger EMR systems that have the like the Care Everywhere or the Cosmos model inside of Epic, which is the one we use, it's going to be even greater that you're going to be able to get more and more data sets to be able to do your population health analysis on. But it's going to play really, the more and more models we get and the more learning and the precision medicine we get in it is really going to become key in forecasting the patient outcomes faster. The AI-driven tools, they enable personalized decisions, because it's going to not just be a generic, more of a, if your counts are this and this, then you're going to probably get sepsis. It's going to actually be able to dig deeper into things and trends, and also maybe even, they're talking about even taking it into your family members. If your family members have consented that you can all be considered in the family inside of the EMR, it's going to start going into your family history and pulling things out that are going to also be able to predict things even faster for us. But all of this is really, truly about, again, predicting so that we can reduce the readmission rate. And then AI really accelerates the biomedical research by, like I said, uncovering patterns in complex data sets, aiding therapeutic target identification, and it optimizes clinical trials. This is really where we're seeing it exploding, is in our clinical trial usage. But additionally, AI also, you can't forget about the administrative back-end tools that it's doing, especially in the natural language processing. It can take an outline, say even for like a presentation like this, I could create an outline, and then I could send it into the Microsoft AI engines, and it can spit out the shell of a presentation in no time. That would normally take one of us, you know, a couple hours to fine-tune your research presentations. So it's really cutting down that efficiency as well, but that also has risks. So you really need to decide at your institution, is AI considered a strategic enabler at this time for you? We all want it to be, but is it at this time, or is it still kind of in the unknown? It can drive better patient care, and it can drive better research, and it can drive better innovation, but that's only if you're doing it in the controlled manner. Open research environments, they pose unique privacy challenges, which requires a lot of ethical safeguards. And ethical safeguards are not necessarily technical. There's a lot more administrative. Is your IRB ready for this? Do they even know how to ask these questions? Do they even know how to evaluate whether or not things should go? And then do you have like an AI governance board that's actually vetting all of these so that the IRB doesn't have to do it? All of these are kind of the new and emerging trends in the organizations on how to try to get ahead of all of this. But also, as our students are coming up, and they are growing up now in a world where AI and these types of things are just at their fingertips, they're going to be expecting it to be in their educational world. They're going to be expecting it to be in their research world, and they're going to be expecting it to be in the clinical setting, helping them along. Are we ready for that? And I say, as an industry, we're not ready for that. We have to, but we're forced to be in here, because there's so many threat vectors that are going into the world of AI, because like I said before, it can be images, it can be natural language processing. There's all these different types of AI. It's too general of a bucket. So what we're doing is we're taking it into specific models, specific use cases, and we're trying to do what they call threat modeling, to try to figure out how could a bad person, a bad actor, inject bad data into that and poison the model. If we're going to be using it for predictive analytics or clinical decision making, we cannot have that model tainted and poisoned. We have to be able to trust the model. So how do you put parameters around the model learning and the data being fed in it to make sure that it's actually has integrity and is going to output what we want? Those are all very difficult things to do. And they're also things that are taking a skill set of people that are not necessarily thought to be doing that. When you take mathematical numbers and you punch it into something, you expect the mathematical equation to be done at the end. Now, when we put it into the system and it's learning and it's shifting and it's not necessarily the same equation you used before, that all introduces risk to your outcomes. And how do we make sure that the shift in the algorithms and the shift in the equations are not shifting too far that it's giving us the bad results? And then also the model theft. So if you guys come up with your own model that does something, how are you protecting that model so that bad actors can't steal your model? What are you putting around that? Where is that model living? Is that model living inside of your container that you have all these other security measures around it? Or is the model living in an open and free commoditized place where anybody can download it? Because if anybody can download it, anybody can change it. So what are you doing there? How are you doing research across institutions without putting your models and stuff at risk? These are all things that we have to think about. And it actually gets very frustrating for some of our users because it slows down the process of innovation because we have to think about the protections of these things. When you get into healthcare specifically, and I am not a healthcare, I'm not a caregiver, but I've been in the healthcare environment for over 20 some years now. I understand that the risks to the misdiagnosis. I understand what it does to the health, what it does to the healthcare system, and then what it does to the patient's lives. We have to make sure that the models that we're using have controls in it, so it can even tell you if it's drifting. How do you, or what tests you have with data that you know for sure that if you put it through, this is the result. How many times do you put that same data set through to test it to make sure that you're getting the same results so that you can prove that it's not drifting? And then, like I was saying before, if you don't anonymize the EHR data enough to put it into the model, you might accidentally be doing a privacy breach when it comes out the other side, or they can reverse engineer it back to figure out who the patients are. You gotta be very, very careful about the minimum use. So it goes back to standard HIPAA language of minimum use, but make sure you're only putting in the variables that are needed for what you think should come out at the end. And then not only do we have to worry about HIPAA here, but in the European countries, they have to worry about GDPR. But more and more, I'm thinking that the federal government is gonna start putting more and more restrictions on AI usage, AI models and whatnot, not to be used, but to be, that you have to make sure that they're trustworthy in order to use them for clinical decision making. NIST, the National Institutes of Standard Technology, have already come out with some AI risk management framework and some AI guidelines. Of course, they're just guidelines at this point. And again, you have to look at it in the different buckets of the different types of AI. But I think that it's all shifting towards that way. But really, truly, in the healthcare setting, it really comes down to patient trust. And like I said, it's all about how can you prove that your models are trustworthy. Patients expect that the answer that the physicians give them for their diagnosis is accurate, correct, and that they can be treated from it. That's what they expect. And if things get like wishy-washy in their charts, or they feel like the physician or the caregiver isn't doing the human check on it to make sure that that actually makes sense, they're going to lose faith in you, the caregiver, and the system. And then, like I said, as more and more compliance comes out, we're going to have to step back to this model testing and model basically proofing to make sure that the models we're using do give us the results we want, and again, how can we test that they haven't been poisoned? And all of that's going to go down to even the scientific integrity, because you do not, that's the last thing in the world you want, is to have to deal with a research integrity claim or audit and then have to go and try and prove that this model really did do what you wanted to do when you haven't tested it for shifting, you haven't tested it for data poisoning, you didn't have any of that built into your protocols. So that was kind of doom and gloom, but we're going to talk about some best practices now. And I promise. It's not doom and gloom, but it's not an easy path forward either. But really, it goes back to governance. And governance has nothing to do with technology. It's all about people and process. And it's all about really understanding how are you de-identifying data at your institution? Are you using a tried and true de-identification engine that is signed, sealed, and delivered? Or are you using homegrown algorithms? Just as I was saying before with the models and the shifting and all of that, if you're using homegrown algorithms, which many of them work, and we have some at our institution too that work, the fear is that it's going to take so much more effort to prove that they were correct than it would be to just be using a commercial off-the-shelf system that guarantees their work. So that's actually where we're shifting towards right now, which has taken a lot of unpacking through the scenes, but that's what we're doing right now. And then also, how are you doing model development security, like I said before? How are you not only protecting the models as your teams are creating them, but how are you protecting that they're not shifting and that they're not learning bad behaviors? You have to have all of that testing in there and to the validation and testing part, because you have to be able to reverse engineer and prove that your clinical diagnosis was correct, that your research outcome was correct, and if you can't reverse engineer it and you can't prove that you did any of these things, even if they're people in process, not even technology, then you're not going to get very far if you have a research integrity or a malpractice claim. And then once it's in place, how do you protect it? Well, you have to continuously monitor the model, like I said, and you have to continuously put disruptions into it, put the raw data that you know is correct into it, and keep testing it. And keep testing it and testing it and testing it all along the way. You can never just put in, forget it, and think that it's going to be okay. That's not the way the AI algorithms work in the back end, and it's not going to be a successful implementation for you. And then you have to log. You have to log when you used it, what you used it on, if you're using it for clinical decision support, you're going to have to track the MRN number or something like that so that you can go back, like I said, and audit and verify and whatnot in case there is an issue later on. And then access controls. Access controls are the fortress around it that says only certain people or only certain processes can even use this model. That's going to protect the funnel of misinformation getting into it. If only certain systems are allowed to send the data and only certain people on those systems, then you can have a more trustworthy process as well, because you know who is doing what, when. And then even environmental segmentation. This is really hard in academic medical centers because everybody wants to have equal access to all sorts of information and equal access to tools and whatnot. But you really need to start building enclaves. And if you're going to be developing AI models and developing all of these things, you can be in more of a free-for-all enclave that still has all the auditing, logging, and all of the monitoring on it, but it's more of all the de-identified data sets, and it's a playground. Once you get into actually once you get from building your models and you're actually going to start using it for a research study or clinical decision making, you got to move it into a more of a protected enclave. And that enclave needs to be locked down. Again, locked down and be able to be tested by the individuals who are testing the models to ensure the integrity of it. And like I was saying about the governance, the regulatory alignment, NIST is starting to dabble in this. HIPAA, there's not very much that's coming out in the security rule that's really concrete when they came out with their new one, but it's going to happen here sooner rather than later. And then even with the FERPA stuff, we got to be really careful about our student data as well, although it's not as regulatorily, it's kind of loosey-goosey in my mind. It's still, there's going to be outcomes and negative outcomes if students feel that their privacy has been affected by any of the AI we do. And that's where it's not even the research or the clinical world, that's more of the administrative world for universities. That's where we're telling all of our administrative staff to be very, very, very careful about, again, treat it almost like patient information, minimum use. What are you trying to get out of it? If you need to know how many people are registered for, these various types of classes, you don't need to know the student that's registered in it, right? there's ways to trim it down. There's ways to de-identify it, just like we do with PHI. And then this is the biggest one that I think a lot of institutions miss, which is the institutional oversight. We are actually in the process. The University of Nebraska Medical Center just published their version of the AI guidelines, which they could be a little bit more stringent, but it's a base at least. But one of the things that we're coming out of that is that we're going to have a multidisciplinary AI governance board. And people are like, oh great, here's another governance board. But we're going to actually turn it into more like a Shark Tank. And we're going to have, if you are a clinician, a researcher, an educator, and you want to look at using some new widget or some new model or some new thing, you're going to need to come to this committee, and you're going to need to pitch it. You're going to need to tell us what you want to do with this, why you want to do it, what you think the goals are for you to do it, how are you going to test it, and then they need to come back and tell us whether or not it worked or not, because so many times in academia, we allow a piece of software to come in, and then that software is here forever, right? We can't have that, not in this world, not in this, when we're just on the edge of testing all of these things. So it's gonna only be able to be deployed in a very contained environment, in a contained way, in the little sandbox enclave. But then they're gonna have to come back and say whether or not it worked or not, yes or no. And if no, we're gonna take it out of the environment and they can try another one. It's gonna really force people to be open, honest, transparent, and very agile. And that's kind of a stretch for some of us because they're going to change all the time. And then if you put in this, model, or you created a model and then you decide that there's a different use case for it, you're going to have to come back again and repitch it to us. Not like a full-blown presentation or anything, but at least just come back and justify why you're going to shift it to this other use case. And then, so we can actually have a catalog and a logging of all of the things too. Because if you don't know where your AI is, and you don't know what it's doing, then good luck in ever putting any guardrails, even if it's just administrative around it. But then the vendors, every single vendor that you will go to any conference or you have any email from, all they talk about is their AI widget and their AI module. Every single one, even though some of them are just algorithms behind the scenes, they still call it AI. Every single vendor is coming out with some version of this, and theirs is their best thing ever. So what are you gonna do with all of these vendors? Are we gonna turn it on everything? How do you know what they're doing with it? If they're an on-premise, you have a little bit more controls on it, but if they're SaaS-based, you'll have way more compute power that you can do with it, but what are they doing with your data? Are they using it to train their models to make it better? Well, you better check that, because if it's your proprietary data, I'm pretty sure your legal department would not want you making them richer on your data. So lots of things have to go into this. You got to go back to the legal department, get contracts all revised for AI, and then you have to also continuously monitor your vendors, because a lot of vendors will turn things on when you do an upgrade, or they will just, if it's a SaaS-based solution, they'll just turn a feature on and you'll have no idea that they're even using it or using your data to learn their own models. So you have to continuously monitor your third-party vendors. And this is where, if you don't know what you're putting in, you're never going to be able to monitor it. Okay, I'm trying to talk fast so we can have questions at the end. But so where are we going with all of this? And there's a lot of trends that are happening, and the future outlook of AI security is really evolving and changing right now. I was just talking to one of the leaders at my institution, and I was telling them it's almost like a colander right now, spaghetti, right? There's so many different models, and there's so many different things bleeding out, and we're really just trying to plug the holes right now and contain it. But how do you do that? And then how are you going to be able to handle the new federated learning that we're all doing? We're doing research studies across numerous institutions. We have to share data. We have to share tools. We have to share all of these things. How are we doing this to be able to have our model be also used at, one of our other institutions or one of our collaborating institutions, but yet we're not sharing raw data and the outcomes are not going to cause a privacy breach and all of that? Well, it's going to be, I call it like widget talking to widgets. And it's going to go more into the agentic AI world where you're going to connect to something, it's going to crunch something, they'll connect to something, and then there'll be a data set in there that is agnostic that you can do research on. It's really kind of it's a great concept. It's just, is the infrastructure there to support it right now? I think it's getting there. Some of our cloud providers, AWS and Azure, are doing a lot of things to try to help the research academia world get more federated, so we aren't also inventing the wheel ourselves. We can use their pipelines and their feeds that are already there, but it's not there yet. And then also, if, I don't know what happened. Somebody? No? Well, I think it just went to sleep. Okay. So, and also, if you do federated learnings across across different sites, and you do this with limited data sets, you actually reduce the amount of privacy creep that could happen. And then also, there's also the differential privacy concept, which is you can add statistical noise and stuff to make it be so that you don't notice that you're always doing this analysis on the same zip codes or something like that. You can put in some noise so that you, at the end, can see, you know what your trends are and you know what the noise is and you can discount the noise. And then also again, going back to healthcare use cases, how do you use these training modules on the EHR but still stay compliant? Okay, so the U.S. has started enacting some executive orders and federal guidance, like I said. NIST's guidance on AI is pretty good, but it's very much in a what type of data do you have and all that, and it's kind of loosey-goosey, but it's getting there. But really, truly, it's really focusing on AI accountability. How do you prove to people what AI tools you're using, or if you're using AI at all? We found that some tools actually are using AI and different learning, different models in the background, but they didn't actually disclose it inside of their, when we were doing their risk assessments on them. So it's really truly is your vendor management system and how you're intaking and evaluating all of your vendors. Are they doing the due diligence to really ask the questions to make the vendors be open and honest about their own systems too? And then we really do think it's going to go global. What the patients inside the United States feel, or even what the students feel about their data, is no different than what they feel globally. And so how are we going to make sure we're not going to be able to have different regulations and different standards inside the United States that we're not going to be able to have globally? It's just not going to happen. But really, truly, like I was saying, the only thing that's going to help us is really if your entire institution from the top down embraces this. They embrace the need for the technology. They acknowledge that it's here and it's not going anywhere, and it's not a bad thing. It's a great thing. But how do you make sure that you have ethics boards looking at it? How do you make sure that you have like I said, the IRB and all of those boards? How do you make sure everybody's educated enough to understand what questions they should be asking, how they should be asking about research integrity and healthcare integrity, and then how are you going to be able to catalog and log these things so you can continuously go back and ask about them? And also, like I was saying, the AI in demand for the clinical decisions, it's all about speed anymore. It's all about speed. So how are you going to be able to trust that what you get in such a manner is the right outcome? The physicians can't do that themselves. You're going to have a team. You're going to have a team, a technical team that is testing the algorithms and testing the things for the clinicians to feel trustworthy, right? So that they are confident that the output that came from this widget is the right outcome for their patients. And again, like I said, it's the trustworthiness. I talk about this actually in many, many different forms, not just in AI, but it really comes down to, can we trust the data, and do we trust the process, and then therefore we'll trust the people? Because technology only enables processes, and processes enable people, and really we're all about people's lives. So how are we making sure that everything is kosher and right, and people feel confident in what we're doing? this is just a little bit more details than some of those things I was just talking about, but really AI and precision medicine is really, it's one of the, I think one of the things that we're going to see the most probably in the next 12 months, but it's really getting into that genetic data, and it's going to take that genetic data and those and analyze it in ways and speeds that we've never seen before. But again, it goes back to what models are you using, how have you tested those models, and how have you proven that they work on the subsets that you do before you put the bigger ones in there. What really comes down, again, going back to the playground concept and the enclave, the synthetic data, if you have a good data set of synthetic data that you can use to try to train the model or prove the model's work, then that's your golden ticket. That's your golden ticket to be able to put it into the real world use. And then from my perspective, from an information security perspective, all of our tools that we're having are having more and more AI built into it so that we can monitor and respond faster. Just like the clinical outcomes, we can actually look at noise. We have millions and millions and millions and millions of logs every single day. My institution alone, in any given month, gets about, I think, 185 to 195 million emails into our institution in 1 month. Our tools have to be smarter and faster in order to say whether or not it's a legitimate email or not. And then we still block probably 85 to 90% of those, and they still have bad actors getting in. So it's the same concept. You gotta go faster, smarter, and be able to prove how you did it. But it also goes down to people. Is your workforce ready for this? Are your, not only the workforce people that are gonna be doing the AI training, the AI creating, but like I said, back to the administrative people that are gonna be allowing it, do they understand what it means? Or does everybody just think that AI is ChatGPT, which is a great tool, but that's not the only thing that it can do? And then how are we training not only our future clinicians, but our current clinicians? How are we training them to know, again, what is safe, what isn't safe, what is approved and proven, or what is cutting edge and you should use, but use with caution? How are we making sure that our clinicians know the difference in all of those? And then how are we doing with training programs for our students, faculty, staff, researchers? How are we doing that? Or even our friends in the community. We at the University of Nebraska Medical Center feel it's our responsibility for the entire state to make sure that we are training them on all aspects of clinical safety. And we've put digital safety into the mix of that. So it's my job to speak to everybody across the state of Nebraska about what are you doing in your healthcare institutions. Are you guys doing that? Are you talking to your community hospitals? Are you talking to your friends and making sure that everybody knows? Because it's all about everybody. And how are we doing this? And how are we ensuring that our staff and our friends are continuously learning? It's a challenge. And so again, AI is not going away. It is one of the most fabulous tools to ever hit our generation. I think it's going to be revolutionary to the speed that we can produce clinical decisions, the speed that we can do our research, and the speed that we can even do just even our administrative functions. It's necessary. My youngest child was actually born in 2008, so I kind of didn't pay attention to birth rates post-2008, but there's a really nice graph showing that after 2008, the birth rates in this country have gone way down. We're not gonna have the workforce, we're not gonna have the clinicians, we're not gonna have these people coming up the pipe to take care of everybody if we don't learn how to work smarter and faster. Because we're just not gonna have the people. So we have to embrace the AI technology, but all I'm asking you to do is embrace it cautiously and take it step by step and listen to the people that are saying, whoa, let's find a different way to test that to prove that it's right. Because it will change the world. We just need to change it safely. Is there any questions? I'm sorry, I tried to talk fast so we could have questions, because I think this is an exciting topic. And I was looking at all the boards and everything, and there's some really cool research and really cool things going on. So then you have to ask yourself, were you thinking about all these things when you were creating those?
Oh, yes, come.
Hello, thank you so much for such a great talk. I am very curious about devices and how they are regulated because they can be hacked, right? Imagine a wearable a patient has, and I'm so very curious to know what are the regulations or the insights that you could share on how we regulate those devices and prevent them from being attacked.
So like a biomedical device wearable?
Correct.
Yeah, so those are really tricky and hard. They're even harder than biomedical devices that are in the institution, but those are also tricky and hard. You have to think of them in two different ways. One is there's consumer ones, like my watch. And I think that when we ingest things like that into our medical record, it kind of goes into, we have it going into kind of a bucket where the clinicians decide whether or not they think it's accurate or not. Then you have things like, it's a consumer, but it's like your diabetes pumps and things like that. Those, I believe, are even more, they're more trustworthy, right? So if you have something that is, the FDA is really getting good about making sure that not only are the devices that are FDA approved are required to have cybersecurity controls around them, and they're required to be patched, and they're required to have their flaws fixed. Whereas Apple is up to me, right? So I think that those are two different things, and I think that you can use both of them, but you must use something like this to supplement something that is an FDA or like your heart monitor or things like that. So that's what we're doing. We're not allowing, this stuff can go into kind of the noise inside the medical record, but not into the chart, whereas we allow the diabetes monitors and those types of things, or the, when we send somebody home with the heart vests, like those things are what we consider in the trustworthy. So that's really what you have to do, is you have to evaluate the trustworthiness.
Thank you.
Hello. Oh, yeah. My name is Leela, and I'm into the cyber field research and healthcare. Okay. So first of all, thank you for the great insights. So what are your thoughts on incorporating AI in the cyber governance frameworks? Will that help in making it more ethical and responsible?
So the question was, what do I think about AI governance
Yes.
in the frameworks?
Yes.
I think it's going to get there, but I think we are going to get there and need it faster than the governance frameworks are going to get there. So we need to be thinking about what should we do in hopes that the frameworks and stuff come after us. But it all goes down into risk management. And are you evaluating the risks of your AI and the entire life cycle of it, from the beginning and intaking it or designing it or creating it? Is the same as if you bought it off the shelf, right, from a vendor. Are you doing all the due diligence then? Are you doing the due diligence while it's being used? And are you doing the due diligence to get it out of your system if you prove that it's too risky? So it's really a life cycle. It's almost like software life cycle management. It's just another function of the software.
Okay.
And if you don't have that built into if your IT and risk management teams don't have that built in, I don't think you're going to have governance on it at all.
Got you. And one more question. So I believe you've heard about the NIST frameworks, right? Nationalized standard frameworks for risk management. So they have incorporated a sixth principle called governance into their frame. Your thoughts on using that framework into AI governance? Like using NIST for AI?
So I don't get paid by the federal government, but I actually really do think the NIST CSF Framework 2.0 that included governance finally in the whole plan is the right way to go. Okay. So I think that the AI governance is just another piece that sits inside of the entire governance and lifecycle management. I think that piece was missing clearly for all these years, and I think it's a great enhancement. But the question is how many institutions have actually adopted it? It just came out in the last year. The NIST 2.0 came out in the last year or so. The AI stuff is just coming out as, more guidelines. So how many people are actually revising all their policies and procedures to follow it? I don't think that many yet. I think you need to.
Okay.
That's where I would go.
Thank you so much.
Any other questions?
Yes, I have one.
Yes.
About the security,
the entire topic is dead, but we've seen a rise of the entire field of cybersecurity when IT systems came up, and we have these hacking systems, white hat hackers and stuff, and the stress tests and stuff coming to AI. Whenever I study about anything about AI and the benchmarking, like you spoke about, the very prominent element in that was around the prompt engineering or having words that might confuse the AI or make it behave badly, basically. So what are the other elements, or what do you think is the good starting point for the entire security as that of cybersecurity?
That's a loaded question. Where do I think the starting point is? I think that the starting point is going back to the basics of identifying what do you have in your environment today, what is the risk each of those do, because if it's frankly not on high risk data and then we'll worry about that later. Not that you don't need to worry about it, but we'll worry about it later. You need to prioritize what you have in your environment, the risk it provides. Then you need to go back and figure out what elements of that type of model you need to secure, and how can you test it to make sure it's not been poisoned and to make sure it hasn't done drifting. Okay. So it's really about inventory. If you go back to what she asked about was the NIST Cybersecurity Framework 2.0, it says you got to identify everything. If you don't know where your data is, you don't know the system, you don't know the AI tool or the engine, you're blind. So you have to identify everything. Then you figure out what tools do you have or testing do you have to detect if it's not working correctly. Monitor. You got to monitor them, right? Then you got to detect if something looks out of whack, right? Then you got to go back and you got to fix it. So going back to the poisoning, how do you then retrain the model to get the poison out, right? Do you have a snapshot of the model before, where it worked before? Because if you have snapshots of the models, you can just basically delete that chunk of time and go back to the other one. So that's a way of going back and preventing it. Then how do you prevent it from happening again? And then how do you recover again, right? And then the governance around all of it. So if you don't do that with every single model, and it sounds daunting, it is. That's why there's teams of people that are required to do this. And if you don't do all of that in the whole life cycle of it all the time, it's never going to be successful. It's never going to be trustworthy.
Yeah.
It's a doom and gloom, but we'll get there.
Yeah, that was my second question, basically, because we have a lot of models and the sub-models coming up, and people working on it from all regions, from all sides. Mm-hmm. And we're talking about benchmarking, understanding the model perfectly well to actually deploy it and then have more control over it. And then how do we come up with these frameworks or the standard benchmark? If suppose prompt engineering is one of the main factors, is that one point that we have to fix around all the models, or what are the set of factors? But I think I got the answer. Yeah. Thank you.
Excellent questions, excellent answers. Any other comments and questions? Lisa's presentation your presentation always impressive. Thank you so much. Yeah, my takeaways, because she's very well organized presentation, system perspective, right? Provider perspective, and learner's perspective, and legal perspective. It's a lot of ways of what aspects we should take account, right? So I'm very interested in AI literacy project, and I came to think about to what extent should healthcare providers should know about AI security or AI literacy. That's kind of my takeaways. So this is very interesting and thought-provoking, the presentation. And also luckily we are living in AI era. We're not living in yet AGI era. So this is a good thing, because I was very interested during the whole presentation is about the AI in the personal health promotion modeling. So because I really like the French fries, but based on my personal data, if AGI is blocking the order of French fries, how can I live? Now think about that. in the world, because of AI modeling, do not allow me to buy the French fries, right? So that kind of era is AGI era, not an AI. So luckily we are living in AI, but we need to be prepared for AGI era as soon as possible. Anyway, thank you so much. Let's give her a big applause.
Testing, 1, 2, 3. Elvis has left the building. Okay, good.
Are you okay? Thank you, Johnny. Well, welcome. You can see we're a very special panel. The first thing we did, we rearranged the house and the chairs. Well, we're delighted that you will be here this afternoon with us and you stay for the last panel. I'm the moderator, and I'm Anna Cleveland. I'm a Regents professor, the Sarah Lowe Kennedy Endowed Professor, the Director of the Health Informatics Program, and recently an affiliated faculty in the Department of Data Science for the College of Information at the University of North Texas. All that means is they keep me busy. So today we have a panel, and it is What's Next for AI in Healthcare. As we were looking at the questions for the panelists, and they're going to introduce themselves in a minute, it is that we were thinking the questions will be around what is the theme of the conference? Practice of trustworthy and responsible AI operations in healthcare. So with that background, and I said we'll start introducing our panelists. They have been told that they will have their name, their title, and the name of their institution, and we will go forward then to be sharing our questions. Sharon, what about we started with you?
Good afternoon. I'm Dr. Sharon Blackerby. I'm a clinical assistant professor here at UT Arlington College of Nursing and Health Innovation.
Hi, my name is Joni Patton. I am the CNIO for Texas Health Resources.
Hi, Susan Fenton. I am a professor and vice dean for education at the UT Health Houston McWilliams School of Biomedical Informatics.
My name is Herman Osterwijk, and I'm an AI imaging consultant.
Krish. Sorry. Good afternoon, everyone. This is Krish Purushothaman. I'm the Vice President of AI Automation at CTS Tech Healthcare.
Well, thank you. We have a very diverse members of the panel to really represent the diversity that we have in healthcare, especially when we are addressing, thank you, especially when we are addressing the different questions. So, like I said, we were looking and see what was the theme of the conference that we have, but at the same time, we wanted to identify some key areas that we thought that would be of interest to the audience. So the first area that we want to be covering is dealing with ethics and governance. And actually, after I read the question, Herman, we would like for you to be the leading in here. So let me read the question. As AI takes on a bigger role in healthcare, what ethical and governance measures are needed to make sure that these systems are safe, fair, and accountable?
Thank you, Anna. You heard a lot about ethics and governance this afternoon, and I'd like to add two things that I haven't heard this afternoon. First of all, when we talk about ethics, about fairness, there's the digital divide that we talked about. But what about the financial divide? If you're a woman and you go get a mammogram, you can opt to pay for $40 to get your AI done. You go to Plano, where people are relatively well-to-do, 60% of the people, of the women said, sure. You go to South Dallas, maybe 30%. Is that fair? Another thing that I didn't hear about is governance. We heard a lot about governance in academic institutions. Well, they can afford to have a big governance board. I'm also on the board of a small FQHC here in Denton. They have a part-time IT person. How are they going to structure the governance for that? So two things to think about: financial divide and governance for physicians, small practices, and FQHCs. Thank you.
Do we have any member of the panel that would like to add that? Johnny?
So with the ethics, so one of the reasons I'm up here is from the operational side. So a lot of the things that go on with AI and the ethics and the governance and the other piece, we have to make actually work at the bedside, and that's where I come into play. I help fill that particular gap. And one of the things that we work with ethics and with governance at the bedside is really making sure that not only from a leadership perspective that we have an idea of how things are being run, but then how it's really actually being done at the bedside, and there's a communication between those different levels and a good feedback loop, so that as you are getting things done, if you're finding that you're having a gap in that's where we might be able to apply resource, or that there's something else that needs to be done that we need them to figure out, okay, do we need to stop doing something over here so that we can begin to do what we need to be doing in the other space?
Well, I think that leads very nicely to the other area that we have been wanting to talk about, and that is health practice. So since you have been talking, what about you follow on this question? What are the challenges and opportunities involving integrating into AI into the practice of healthcare?
So at Texas Health, I'm very proud of us that we try to be very innovative and very cutting edge, sometimes bleeding edge. And we have been implementing several AI features within our Epic vendor. And the ability for the staff to be able to understand what the tool is, how to best use it into practice, and then how to grow that as you go across practice, that's very difficult to do. And the challenges that you have with that are not only from the education standpoint and from the competency standpoint, but what is the tool, the trust standpoint that we had a discussion last week as a panel, so there are several things that we'll have themes on, that the trust that we have from the clinicians, that the tools that we're presenting them are actually being able to be used. And one of the phrases that we like to use is licensed human in the loop. So in AI, you will always hear that you should have a human in the loop, and we've had several of the presentations. There needs to be somebody in the loop that's really paying attention to what's going on. When it comes to healthcare, there needs to be a licensed human in the loop, meaning, the AI is great, but it really doesn't have a nursing license. I do. It is my responsible use of the AI that is one of the challenges, because they will become to the point where they trust it so much that they might trust it too much. And that's one of the challenges and opportunities, is helping them to trust it and then finding the right balance between trusting the tool and challenging them where you need to.
So, Sharon, I see you that you're ready to follow up on that.
To tag on to Dr. Patton, along with the trust is responsible use. You've got to have critical thinking that never goes away to be able to know that the information that you're using, that you can trust it, but does it make sense? Is it right? You've got a license, regardless of whether you're the physician or physician assistant or nurse practitioner. You've got a license, pharmacist. You've got a license that you have to protect, but you've got to do right by the patient and know that it makes sense. Critical thinking will not go away with AI.
It should be augmented by AI.
I think, Herman, I noticed that.
Yeah, part of your question was about opportunities.
Yes.
And one of the things I haven't really heard today either is the opportunities in LMIC, lower middle income countries. When we think about an opportunity to deploy an AI algorithm to improve the diagnosis or the detection for breast cancer, that's one thing. We can maybe improve it from 95% to 97%. I work as a volunteer in Africa sometimes, a couple of times a year. There's no doctor, there's no radiologist. So instead of from 95 to 97, we go from ground zero to 75, 85, a huge impact of AI. So one of the things that sometimes I think we are a little bit, including myself, too focused on what we can do in this world, United States. And I know there's so many people that come from different countries originally. There's a huge opportunity to make a big difference with AI in these countries.
I think this is a very good balance for your remarks, because we can really emphasize in a reality in terms of what the challenges are. And I see Dr. Patton, Joni for me, Sharon.
It's Joni for most people.
I will tell you that it's easy to see that. And I think that we also look in the horizon, this horizon that we have, that is there are also opportunities, and we have to take those opportunities on how to overcome the challenges, because I think that's where the future of AI in healthcare is going to stay, Well, I think as we're talking about this really leads us into another area that we want to talk about, and that's data and technology. And we cannot escape it. Oh, what am I doing?
Sit closer.
And I thought I was loud enough in my classes, my students. I guess I'm not loud enough here. Oh, so the next question that we have, it is, what are the key technical challenges in using healthcare to train, I would say, reliable AI system, and how can we improve data quality and interoperability between the systems, especially when they come from different sources and different platforms? So I think, Susan, you are ready to tackle this question.
I'm going to start, and then I'm going to rely on the others to help. So anybody who's ever worked with healthcare data knows, right? Incomplete, okay? Inconsistent, and often, especially if you look in a healthcare organization with all the different feeder systems, lacks standardization, right? They can do gender and sex in many different ways, just depending on how they chose to do it when they set that system up. So that makes it hard. I think we're also facing a significant technical challenge because we now know enough to know that we need to be checking the training data set against our population that we're intending to use it against, but we don't have a standardized way to do that, nor do we have, okay, what constitutes an acceptable benchmark? If you do the testing, what's acceptable? We're still working on all of that. Obviously, privacy, security, compliance, those are huge issues. We have a draft AI policy now that's going to have the compliance hotline in it, okay? Our CISO has people who do nothing but review contracts for the AI that's coming. Everything you buy now says AI, right? So you can't buy anything. So what are the cybersecurity implications of that? And then I think we're going to face a big problem with legacy data. And how do we get all of that standardized? In terms of improving it, obviously standards, same for interoperability. We just have to keep hacking away at it. We're a lot further along than we were, but we still have a long ways to go. So I'll turn it over to my colleagues.
Chris?
I can comment. So working with IT applications, what we have seen is interoperability has been a major concern, especially pulling the data from either from patient records or getting the data from payers, from insurance information. we have standards across the board, like fire standards, and then in information exchange. All those things are there, but still this has been a continuous challenge. Now that the industry is moving towards AI, and we need a lot of that data to be consolidated and cleansed so that we can effectively use that. So that is going to be a constant challenge that industry is evolving, even though we have some standards in place.
Well, I think that data exists, and accessibility of the data is not really that much of a challenge. I mean, if we look at it, because the technology is here. And so I think that the key word in here is quality data. Because the fact that it's coming from these disparate sources, that they have different guidelines and different standards, that's where we are not sure about the control that we have or the quality of the data. And I think that can become a challenge for different institutions.
We saw with Nora today, 2 bills passed in the same legislative session. They don't have the same definition for AI, much less for any of the data that goes into it. So, right.
Yeah, I thought about Laura when she was mentioning, I thought how applicable would be to the questions that we're having here. And also there's a lot of things that, Lisa just finished pointing out here. And so now, Herman, you have been doing a lot with interoperability of systems, and I know. And of course, you have been focusing imaging, dealing the exchange, systems. So would you like to address a little bit of the challenges you have seen?
So thank you, Hannah. Interoperability is kind of my expertise. I've been involved with HL7, THIA, and DICOM standards. But the challenge was, or the challenge is, the problem is today, when a physician looks at an image, he said, okay, I can look at the image. But no, as soon as we start looking at the metadata, for example, what is the body part? Well, let's say we have a CT of the head. Head, skull, head, neck, brain, all of these different terminology that we now certainly have to use to make sure that we have the right information into the learning model. That is not really there. So we have a huge problem with legacy data, right? Because people were not really paying attention to proper coding in SNOMED or CPT4. And so it's a big challenge, interoperability.
Definitely. We were just looking at here, your topic that you were talking about. Johnny, do you want to chime in?
Well, from the operations side, and I'll give another example. So one of the AI tools that we've implemented produces a summary. And so it looks back and it reads the last 99 notes, and it produces a summary of the notes, or it produces the patient story for the particular encounter. And what I found really interesting from that interoperability component of that is immediately upon doing that, I knew that we had a success because all of the clinicians wanted to tailor that down to, well, I want it just for gastroenterology, or I want this just for my care transition management. And when I showed it to the physical therapist, they immediately went, can we have this for just, so that trying to create the story so that it tells what's going on with the patient is great, but you've got to be able to personalize that for the role, which makes it more interoperable, in what you're doing within the system. And I think that goes across what you're saying when you have that legacy data that's coming in, even if it's from your own chart, if it's from a different encounter, if it's from in the past, and then being able to integrate that into what you're seeing now in a chunk that's able to be digested by the person reading it. I think that's one of the things that we're going to continue to struggle with.
And at the same time, once they see the success, you see others coming in adopting. So that's where the trust is being built, and then more adoption happens as an AI story. Yeah.
From a public trust perspective, people read things on social medias and they think that if it's on social media, it must be true. Yeah, read it on the internet. It has to be true. Well, the same is with generative AI. So I kind of think of generative AI in two ways. One is when you think of systems, one's the back end, one's the front end. The front end to me is the end user. So as the public begins to, or some of the people are using ChatGPT, Copilot, Gemini, whatever Gen AI you want to use. On the bottom of a few of them, it says AI content may be incorrect. Well, there's the first clue. They have to, it goes back to what I said a while ago. I call it fact checking. You have to check the sources. So anytime I enter a prompt, I'm saying, give me the resources. Tell me where it came from. Well, we as healthcare professionals and everyone in this room have the obligation to educate the public on where do you get your information from. So Dr. Google now is Google Gemini. So we have that responsibility to educate the public for them to be able to trust the data and the information that they get.
And I think that to add on to that, the health literacy, and several of the speakers today have discussed health literacy and AI literacy, and the ability to understand. The folks in this room, we have, well, most of us, not all, me being one of the ones that doesn't have a really firm grasp, but enough to have my fingernails in, is what's the difference between generative AI and agentic AI and a large language model and to them it's AI collectively, or they're only thinking that AI is ChatGPT and that it's on the entire internet. That how do we educate not only our clinicians but our patients that what we're doing is a safer space, hopefully, AI product that we are using with them, that we're not going to the internet and putting their health record on the internet to get some information back. It really is just your data that we're looking at with this. That there's a lot of that health literacy that we've got to do with our own clinicians as well as with our patients. And I think that's our next hill from an education standpoint to really have to start to climb.
And right there, what you mentioned, healthcare as an organization trying to adopt AI, these are some of the challenges. Like what happens if somebody, takes a snippet of a, healthcare record and then put it on the ChatGPT and then try to get. So those are all like typical violations and security complaints that the organization has to come up with and bring in the, literacy across the organization so that they act responsibly. So that is another challenge that we see.
I think we need to talk about, you were saying, understanding the differences in the different, So AI's been used in healthcare for a long time, for a lot of different purposes. And it's really important. In fact, Nora talking about when that Bill 149 was the first version of that. And Representative Capriglione actually came to Houston and we talked to him about it. And he talked about my dad's knee replacement surgery and him being able to watch that surgery and the scraping and the, and my dad is a retired physician, and so he watched the surgery. And then he literally turned to me and said, when he used to assist with surgeries like that, they eyeballed it. Okay? But that was AI. That was, right? Yeah. Yeah. So that was AI, but that was almost a decade ago. And so reminding people that it's not, generative AI captured the public's attention, but it's been around for a long time. And I say this a lot, no AI is currently licensed to practice any kind of medicine anywhere.
Exactly. I love that, Sharon.
Licensed human in the loop.
That's true. I want to get back to a point here that Sharon, you mentioned. And when we're dealing with literacy, and how is it the public trust what they are reading? Because that has been the norm for a long, long time. Let's look back. When somebody used to say, something was in print, it must be true, and you believe it. So that kind of behavior has been translated. It has been to right now when they do a search in social media and they come to it. I think we have a great responsibility in the healthcare field and those that they are in other fields, in other disciplines like information science and so forth, to show what is the value of evidence and what does evidence mean and how is it that we can evaluate that evidence and how we are sources that can be trusted. I think that is a behavior that is hard to grasp. Even here, we don't have exactly all these strategies. But I think it is our responsibilities in the healthcare field to also educate our patients, the researchers, the clinician about this topic, because they read it, ChatGPT told you, and therefore, Gemini or whatever, and it must be true. So I feel that this is something that we have a gap, that we need to be working on it and be embedded that. So when we talk about health literacy, that's part of it. When we talk about health literacy, data literacy, because how many people really understand right now? For example, they have the blood work, and they get the result of the blood work, and then they go to ChatGPT, and they tell them that the bone is elevated, and this is what they need to do. But they believe ChatGPT, but they didn't believe their physician. Do you see? So how is it that we can come that across to them? And I think that we still need strategies to be built to be addressing that. I mean, that's it. Who do you trust? So with term trust, we come to the next point, which it is, and I think we have been talking about some of this. So it's how can we build public trust? How about that, Sharon? You just let us into this one. How can we build trust, public trust in the healthcare AI, especially around issues of data use, transparency, and the impact that might have in the healthcare, the patient care. And of course, this can be looked at it from different perspectives. We can be looking at it from the perspective of the patient, the healthcare provider, industry. How is it that industry, is trying to see that it's okay. This is going to be worthy in the impact in patient care. So I think that, Krish, you're going to be leading this response on this one.
Yeah, so when we think about trust is the essence for making AI adoption success, right? So what we have seen in your example, right, Johnny, I think there was an instance where, providers saw the summarization would help their specialty, right? So they were able to adopt that solution. That's where the trust is being built. So we work with major health systems across the country, and then the leaders come to us asking for, we need an AI roadmap. We need to optimize this process. We need to bring in AI in clinical automation. So when we started working with the operation managers and the clinical side, we always see that, oh, you know what, this process, might not work. AI might not be able to help. And there is always this fear coming out of various parts of organization, either from providers, from operational folks who has been handling the task. Oh, this is not something that is going to help. So there was one instance where I was working with a major health system where we wanted to automate a process. This is kind of coming up with a risk-based profile on a chronic disease so that they can be prioritized for scheduling. So that they get, and these are the people who is medically needy, they need to get the appointment scheduled on a priority basis. So we work with the operation folks, we work with the providers to try to see how we can profile and then kind of flag it on the EMR so that we can get it prioritized for scheduling. So there are multiple elements, like you were mentioning, Anna. There is a patient data that is needed in this case, and there is a provider involved and engaged. There is always that if we automate it, how do I know that these are really medically needy people, right? So that's another part of. And then the third stakeholder that we see in the equation is we need to get engagement from everybody, like the whole organization and the patient. So it starts with getting the right data, right, the accurate data. As a patient, I don't want my data to be used to profile me. I'm okay to provide my data in a generalized sense can be used to make decisions, right? So that's where the transparency, right? The transparency on how the data is going to be used and how real-time this data can be purged after the use, after making clinical decisions. So that is an important factor. As a patient, I had to be aware of, rather than 42-page legal documents, taking a consent, right? It should be explainable for the patient so that we make use of that data in a way that makes sense for the customer. And that is going to bring in more accuracy as well. And the second thing is, when we talked about the whole process automation, providers come into play. Providers has to be engaged. Like you rightly said, it's not like a human, in the loop making decisions. It's a certified clinician making some decisions, right? So that is where we bring in a little bit of a comfort from the providers that, hey, AI is not making decisions. Human in the loop is there. So you are going to be looped in. At the same time, the decisions that are being made is being explainable to the providers so that you see the sense out of what decisions are being made. So that is another way that we can bring in a trust from the providers. Overall, once we make this process efficient, right, you will see that engagement coming out of the whole group, right? And then once you do this for one chronic disease and then you implement it for other chronic disease. So it kind of, it uses a segue to kind of expand upon across multiple specialty, but the trust is built in the whole process in every step of the way where, we make it more engageable and we make it more accountable, transparency, and then we kind of explain it to the whole audience that, hey, this is the way your data is going to be used, and this is how the whole process is going to be evolving with the providers.
Well, and I'll echo that. So we're doing a lot of work within our virtual nursing, virtual care space. And one of the things that each group that works on this harps back on, comes back to make sure to emphasize, is that when we're explaining the virtual care to the patient, that we're very clear on what it will and what it will not do, and what we are accessing and what we are not accessing, and what they have control over doing, to establish that trust factor, because they're going to have another caregiver in the room that they're never going to see, but that's going to be impacting their care. And so the ability for us to be able to very clearly communicate to the patient, here's what it will do, here's what it won't do, here's what the people behind it are doing for you, is a big piece of that.
Exactly. That brings in a lot of trust and engagement, right, rather than causing more fear. Yeah.
I think that you have brought that aspect very well, both of you. And we have to keep in mind the industry aspect to it. The developer, the companies that we work with. I think that at times there is a mistrust in terms of what is the industry producing? What is the purpose? What is the reason behind that? So we engage them, into the healthcare field, and they're getting embedded. I think also, who is the company? What is the product? What is the efficiency of that product? What is the support that you're going to get the documentation for? You have to build certain trust. And I think if that trust starts there, because that's where it's born, that's the research and development, then it can carry us out all the way through. Right. And I think we cannot forget that link. Always we specialize, as we have talked before, in these angles that we have talked about it. And there's at times there's a disjoint, because a healthcare organization such as Joni will purchase. We have a contract with certain company and certain products, but actually the clinician, the patient, and so forth, they do not know. And often also in the news media, they read something about it, and it's a disparity between what you say you're getting in your organization, Epic. Don't quote me that I say that. Hopefully we're not being taken. But how Epic performs, from the perspective of the patient, the healthcare clinician, and then where are also the issues dealing with Epic. So we cannot forget the industry aspect, and I think that often that is not translated. And the strut at times from the patient point of view is what he reads or she reads in the social media. And that's something to keep in mind to it. Yeah. So I want to bring that industry side to it, because you are one of the representatives for us in the panel dealing with that.
Yeah. So from industry perspective, technology is sort of evolving, right? Yes, AI is not new, like Susan, you mentioned. It has been there. And then yesterday it was robotic process automation. Today, a couple of years ago, it's AI. Now, generative AI. Now, agentic automation. And then there is more of AGI coming in, right? So evolution happens, and the technology disruption happens every step of the way. And keeping up and how those technologies is going to add value in every process, right? Every step is going to be a challenge to kind of keep up and assess what type of governance is needed, what type of security protocols are needed, and how we can manage the products that is coming into the market, evaluated before we adopt on. So those are some of the challenges that we have to constantly assess and keep adapting to that as an industry.
So I'm privileged in my organization that I sit on the AI governance committee, and making that easier within an organization. So when you have a trusted partner, like I said, our EHR vendor is Epic, and we trust them. And so we trust the things that they're doing because we're helping to build that. As part of our governance structure, if it is a tool that is coming from a trusted partner, then we have a different pathway that is faster but still rigorous to be able to get those products into the hands of the clinicians to use. Where if we have a product that is being proposed to us that is perhaps not from a partner that we trust, there's a much more rigorous process that you have to go through to do exactly what everybody has said to make sure that it's safe and it's compliant, it's doing all of those things. But we have to be able to understand in the industry who our trusted partners are versus who the people that we want to work with and help, but they're not quite there. There's a bifurcation.
They're not quite there.
Right. And at the same time, you mentioned about EHRs and EMRs, right? Organizations struggle, like, any application that you take, now these days you cannot find an application without AI, right? So even a simple use case, simple automation, you'll see AI. So as an organization like Texas Health or any organization, how do we monitor these models is performing what is supposed to be, right? That governance, you need to have better observability. You need to have better monitoring system to make sure that, these models are making right decisions. Are we getting really the value out of these models, making decisions and all that? So that's going to be a constant challenge that, we need to keep up and monitor those tools that is coming in the market.
Yeah, so this week, I received messages for the release of 2 different tools from 2 different companies for helping organizations with that. So those tools are coming because I think everybody's been trying to build it from scratch, right? But you need tools to help you, just like cybersecurity, right? Nobody does it from scratch, right? You have tools to do that for you or to help you with it, and then you have humans working with those tools. And when you were talking about the rural and everything, that's really what they need. They don't have any resources, a whole lot of human capital to throw at it, right? So we need to get some easy buttons for them, if you will. Yeah.
I'd like to talk a little bit about the industry and products. Just for imaging, for radiology, there are more than 1,000 FDA-approved different applications. So think about it as an organization, how many, because Epic is just one big, organization, but think about all these different subspecialties. You need one for stroke detection, one for lung cancer, one for the, I bet you that even the low-hanging fruit, there are probably at least in radiology 50, 60, 70 different AI applications. So it's a big challenge. It's a big challenge. And so it's easy to say, oh, Epic, we can trust them, we know them. But do you know a company that provides stroke detection? There was an algorithm created in South Korea. But by the way, most of the algorithms are developed in South Korea for imaging. Or in Australia, there's also a lot of developments taking place. So it's a challenge.
Very much. Well, I think that definitely there are challenges, but also for opportunity with AI.
Of course.
I was going to say, looking at that in a very positive side. The other thing I was trying to recall, one of the presenters, and I think it was Dr. Stephanie, I don't remember her last name. She's from UT Southwestern Medical School, and she talked about trust. I have in my notes in here. And there were 2 things that caught my attention. The first one, Of course, we're all aware of it, which is accuracy. She said, you're going to have trust. Look at what she said, we have to have accuracy, whether it's in diagnosis, whether it's in the treatment, when we're looking at the data that is, producing the decision-making process, for them to make this. But the other thing she mentioned that we have to be very aware of, culture. And I think this is something that often we don't think. Look at all of you knocking your head. We need to think about how is it that we can capture the different cultures in order for the people to really trust, what is it that they're being saying in these systems? What is the output of these systems? How is it that, does it include any culture, behavior of what we are? And okay, Joni, you're going to jump on that one.
Please finish your comment.
Just go.
So we've been working on, right now we have 2 what we call innovation units. And one of the things that makes them an innovation unit is that they have a culture within their unit that they are willing to try new things and provide feedback and do these kinds of things. Well, now we're trying to expand the number of innovation units we have, because they're both, for those of you that are in the hospital space, they're med-surg units. But we know that we need to expand our innovation to our other areas, our ICUs, our labor and delivery areas, our procedural areas. And so what we've been trying to come up with is a standard operating procedure for an innovation unit. You have to have the right culture in the unit.
Yes.
If your culture is not one of learning and willing to fail quickly, and willing to fail, because innovation's going to fail.
Sure. It's not always a success.
It's not always successful. You have to be willing to do that failure. The standard operating procedure for those units is culture. You have to have the culture or it's a no-go. But from the cultural perspective of the ability to pick those things up, one of the things that, and I think there was in fact, I know there was a poster presentation on it, of the ability for the AI to pick up on disparaging language, or where it is being pejorative, where it's using the language that we use, that you're non-compliant. And I'm non-compliant with a lot of things, as we demonstrated walking up the stairs. But the ability to use the appropriate verbiage for those kinds of things that fits into not only the culture of healthcare, but into the culture of the patient or into the community. I think that's one of the strengths and opportunities that we're going to see with AI, is it helps us to retrain what we're saying and how we're saying it so that it makes the most impact to the people we're trying to reach.
So what a great point that you just made to bridge us to the next question. And that's going to be, and actually we're looking into the future, because you said you're doing this, what is it that you're going to do next? So what do you envision as the most transformative use of AI in healthcare? And Sharon, you volunteered, didn't you, to do this one?
Voluntold. I think this is the most difficult question for me, but just for grins, I took a portion of the question, put it into generative AI, just for grins, just to see what it would come out with. And it's amazing how many of these things, even though I used the word future, and I even used the word in 2035 in my prompt, and I came out with the same things. Predictive and preventive care, AI-enhanced diagnostics, robotic and AI-guided surgery, personalized medicine through genomics, virtual home-based care, and clinical decision support. And all of those things we're doing in some form or fashion today. I think what we have with AI today is definitely not what we'll have tomorrow, next week, next year. There are probably people, some of these people, working on those types of things that we'll be using in the future, but do we even have any ideas of what it will look like? I don't. Anybody else want to help me out?
Well, I think, Johnny, you will, but let me tell you what I said always in the class is not what we're doing. but it's how we're going to be doing. So what you have had that listing here, which it's not futuristic, it's because we have it now. It is how we're going to be doing it that it will make the difference. Okay?
So from the operational side of this, again, so we have a new hospital we're about to build. And we're already planning for the innovations that are going to go into it, looking 5 years down the road, how is this going to work? Well, that's great for that brand new hospital that we just, turned the shovel of dirt over on. But several of our other facilities were built in the 30s. And the ability to provide that same level of care in a very old facility that might not have the infrastructure, because it's just very difficult to do, that operational mix of being able to do those things. As we look forward into the future, how do we bring those people up and forward to be able to do that? As far as what's coming up, I don't know about you all, but my staff are incredibly inventive when it comes to what they want it to do. They want the room to do all of their documentation for them by just watching them. And I went, are you sure you really want that? I'm just going to say, okay, be very careful what you ask for because you're about to get it.
Right.
And those pieces of what's coming and what we're going to be able to plan for. And Dr. Marion Ball, who's an excellent friend of mine and sees into the future, it's that ability to train the folks that are coming up to understand what's coming, that change is inevitable, and that you need to train to the point where you're going to be able to change quickly. So as we train for AI, as we train for ambient listening, as we train for those kinds of things to take over the menial tasks in healthcare, so that we can actually get back to what healthcare was really intended to be, which was me taking care of you as a person instead of me taking care of you as a chart. I'm better at the chart part, but that's really what we're headed back to. And that's where I think we need to be putting our sights on, is getting us ready for what's coming up and training the people that are coming up that are going to be taking our place to do.
I think Susan's going to say something, but I want to jump in just one sentence. I don't want to lose the thread. But you have mentioned several times change. And I know that Dr. Ball, having a visionary and an agent of change in the field for many times, and I want to recognize it in front of everyone. But as you say change, we also need to teach people how to adapt to change. And I think that that's one of sometimes it is a drawback, because as you know, a human being, we're so used to doing what we're doing. So adapters of the new technology and so forth, we need to make a point on how is it that we can change that behavior, how we can train people to it. I think that having a gap, actually, in the field. Susan?
Make the new thing the easy thing to do. Make it. That's why ambient documentation is taking off, right? When I think about transformative use of AI in the future, what I want, this is what I want, okay? Puppies and unicorns, yes, and rainbows. Don't forget rainbows. Okay, no, but what I really want is, who here goes for your annual checkups? Right? Almost all of us. Okay, great. I do too. I don't like that. All right? What I want is I want my doctor to call me or my caregiver to call me and say, this pinged, you need to come in and we need to take a look at it. And other than that, they leave me alone. All right? To me, that's the transformative use of AI. All right? And it's combining that personalized care, but not just for genomics, right? Okay, and the predictive and the modeling, but it's putting it all together to say, we only touch you when we need to touch you, right? So that's what I want. That's my transformative use of AI, where they're not going to bother me unless there's a reason for them to bother me.
Let's see, Herman.
Yeah, I've thought about this question, and I'd like to come up with 3 different examples. So first of all, I think the transformation will be mostly for the patients. I was at an AI conference that was organized by the FDA, and the next speaker came up in a wheelchair. He was paraplegic. his story about when he needs to go see the doctor, it's an ordeal. I mean, he needs to get ready, he needs to get the wheelchair in the car. It's really a terrible thing. He said, for me, as a paraplegic, AI is a God blessing because I can do everything at home. The second example I want to give is in Israel, there's a big HMO. They give the women that are pregnant an ultrasound probe. Ultrasound probe, you have these days, they're very inexpensive. You can buy them for $3,000. No, you cannot buy them, but anyway, you can get it for a few $1,000s, but you can connect them to your phone. And what will AI tell you? Position the probe. Go to the left, go to the right, go a little bit up. They, user-assisted AI, will tell a pregnant woman how to do the monthly checkup. So they don't have to go to the doctor unless they really have to. Another example, my third one was, my wife had a small surgery, and so she said, okay, I need to go see the doctor. Next week, why see the doctor? Well, he needs to look at the wound. How can you just take a picture, upload it with AI, so that everything looks clear, right? So I think the transformation is really, hopefully, supposedly for patients, and specifically for the patients that either pregnant women or high risk, or, and then again, just one more thing. I'm involved with a project in Uganda, and we want to give every midwife in that country of Uganda one of those probes with AI. We know that the infant mortality rate will be dramatically reduced, and that is key, and that's how AI can win. So, challenges, yes, but opportunities, tremendous.
Chris?
Yeah, so my perspective is, as we see the future, there are a lot of things happening even today, right? So from a clinical setting standpoint, there are a lot of automations happening in the sense like AI making some decisions with the human in the loop. And there are products out there like a clinical assistant. These are all not licensed assistants, these are all virtual assistants, right? Let's say a patient has been discharged. Somebody has to follow up with the patients to see, are you taking medications in the right way? So is there any complications? Should I get an appointment schedule? There is no limit with the technology. Like any other technology disruption, there is always some roadblocks, especially AI being heavily reliant on data, and especially healthcare data is being so sensitive and cannot be shared across unless we have a compelling case. So the sky is the limit. We see a lot of things happening in terms of clinical automations, in terms of virtual assistant, chatbots, and then understanding the generative AI. It used to be an operational manager going through the contract document, identifying the benefits, trying to read through what benefits are covered and all that. So those things are simplified now. And there is a lot of things in the sense like, personal diagnosis, right? We see the wearable, everywhere, our data are monitored, right? So you aggregate the data and then you will be able to predict something is coming up in the future. That's the excitement that I'm seeing, that industry is moving. Once we collect the data, you can predict personalized medication and then personalized diagnosis, all those things are going to evolve. And one thing that I wanted to conclude saying is that, it has to be, AI is exciting and we see a lot of things coming up. It has to be governed ethically and used responsibly is what I'm seeing.
Definitely. Well, I think we're getting close to the time that we have for questions. So it's interesting because we have been looking at the ethics, the governance, and of course we look about the healthcare practice, and we cannot do this without having talk about data and technology. And of course, I think at the tip of the iceberg, it has been dealing with trust and innovation. But if we look at all these topics and all these issues, we really need to see where is the workforce that we have to be able to accomplish all of this, right? So it goes down to it that how we're going to educate that workforce to be able to see all these things that we are talking about. So the last question is going to be, and hopefully each and every one of you will have one strategy. Simple and doable. That is, what strategies can be used to educate healthcare students, faculty, and healthcare providers in a way that we can teach them the basics, the foundation of generative AI and data literacy. Because some of them, they're looking at some of these applications and hear about it, but do they really understand the foundation aspect to it? And we think, having me talk with the panel, we think that there's a gap in here. So what can we do to solve that? So what innovative strategies have you all come up with?
Well, kudos to Jenny and Kat using simulation. They talked about that in education. That is huge in preparing our future nurses to be able to care for patients. Simulation at UT Arlington and other schools as well use simulation, and that is, I cringe kind of say when I say the next best thing, but it helps prepare the students to be able to go into the clinical settings, to be able to work on the skills that they have learned in the skills lab at our smart hospital. That's been ever so true with, I'm teaching a clinical group right now of first semester nursing students, and it's amazing to what they see, what they remember. Oh, I learned that in the skills lab over at our smart hospital. The other thing related to students and faculty is teaching them how to use the tools that we have that are available to us. Generative AI is one of the things. I have faculty quite often, and Dr. Mary Tietz and I have conversations about, well, how do we teach the faculty about generative AI and how to use it in preparing curriculum, educating our faculty how to develop curriculum with it, but also teaching and implementing it for our students to use, not for AI to write their paper, but to use it in ways that are meaningful for them to be able to practice in the future.
Thank you, Susan.
And I'll extend that into the world beyond nursing school.
Sure.
I think our nursing school, I think all of our health schools, any school, medical school, pharmacy school, nursing school, PT school, pick your school, they all need to be preparing their students with literacy and competency in how to do things as we move forward into the AI world. That extends into my world, is that I have a whole lot of people in my organization that we need to be bringing up to that same standard that we're trying to get the students to. And how do we help our existing workforce that are using the tools today to really use them effectively? Several of my coworkers are here, and that's one of the things that we struggle with on a daily basis. We know what's available to all of our clinicians, but our clinicians are so busy taking care of patients that they are often blissfully unaware of all of the tools that are available to them. And how do we help them cross that chasm and bring everybody up, not just the nursing students, but the existing people in the workforce to the same level of literacy for what we're trying to do with these tools?
It's interesting that you mentioned that point, because I had a meeting with the provost, and he said, Anna, what is one of your biggest challenges right now? And I think I completely threw him off what he thought that I was going to say, budget, the student curriculum, and all of that. I said, the biggest challenge for me right now is to bring up to par the faculty that I have. There are some that they are very savvy, they're experts in their fields and so forth, but the field is changing so rapidly that, I want to see that we have a mechanism for able to be, that they are trained and that they're up to date on what is happening. So I'm just following up with you because I can relate to what you're saying. Okay, Susan.
So I don't know if I have a specific strategy. What I can tell you, there are a lot of challenges. And those challenges exist in part because no one we are training or working with today is a generative AI native. The generative AI natives are in preschool, all right? So even our students, we did a survey. Less than 40% of our faculty felt like they understood the legal copyright issues. More than 60% of our students thought they did. Yeah, all right, okay. So we have some challenges ahead of us. They think they know it, but they don't, right? So then if you start talking to them about, are you gonna give away your intellectual property? What are you gonna do, you know? So strategies, I would say we have to be trying as much as we can to help everybody understand the implications. Challenges with that are access to protected resources, because that costs money, right? So to have something that's HIPAA, FERPA protected in an organization, that's an investment.
Yes,
so,
it's an investment.
and our people who make the decisions about what to invest in have to understand that. So to a certain extent, it's not even the faculty, the professionals, it's the decision makers.
Yes,
So,
so we will talk about the strategy on that one over coffee, how we're going to go. So we need a strategy.
I don't know about you, but if I need to change the clock in my car to daylight savings time, I call my grandson of 16 years old. So what kind of indicates that the younger generation, I don't see so much of a challenge with educating on new technologies, and they're computer savvy and they know how to change the clocks and whatever. It's really us, most of us, we need to educate ourselves and our peers, and I think that's going to be the big challenge. And just as an example, and I think it depends on the individual. I was part of the transition from film, we had some film radiology to people using a computer, and I found that some of the radiologists that were 60 years old were the best. And so 40, 50 years old, they had to learn new skills. So it really depends on the person. You need to be able to change your mindset, and you learn how to use new tools. And I think this will be a challenge. So.
Okay, Christian, we're going to close with that.
So this is the challenge of being last person to respond. Pretty much all covered.
Give us a good strategy.
Anyway, so my perspective is that, so these days, everything becomes open source, right? So it's just a matter of, like what Johnny was mentioning, information is available everywhere, right? Especially in an organization like a health system, when we take, like, things are available. You see the latest technology put in place for work, and it's just that we need to get educated. We need to have that time to get focused on that, and then be trained on that. So it's a matter of getting that focused time on that focused area. You might see, technology changing from last week. People might be talking about, the whole AI now, AGI, and then agentic automation coming in. And these are all buzzwords, right? So when we look into everyday operations, there are certain things that is put in place. And, we need to get focused on those areas, and then create that curiosity to, look into internet and find out what information are available, and then get trained. So I would say, like, focus on the technology, focus on the operations that has been put into place, and then, where the technology, what needs for the technology, and just, be curious to kind of learn more about it, is what I would say.
Well, thank you for those closing remarks, let me say. So, as we look at what we have been talking about, I think that the panel have been trying to highlight that the future of AI, actually, it isn't just innovation. Oh, thank you. It's just, okay. Thank you. So the panel have been trying to highlight that the future of AI in healthcare, it isn't just about innovation. It is about trust, equity, transparency, and operating responsible at all different levels. So if we look at it, we can say that the future of AI has not been written yet. And that is the greatest opportunity that we have in our hands. So to bring it back in a circle to the theme of the conference, those opportunities that we are going to have, we are going to be sure that we see that we're providing trustworthiness, and that AI is functioning in a responsible way, that those things have to be in the landscape of healthcare. So with those words, I want to thank each and every one of the members of the panel, and I think we can clap them right now.
Thank you.
So, how are we doing? Yeah.
We have 2 minutes.
1 minute for questions, once. Over now.
So,
Is this on? Okay. Well, thank y'all, everyone, and all the presenters today. It's an honor sitting next to all of you.
Hold the mic up.
It's an honor to listen to such intelligent speakers today, so thank everyone. I have a question. The word, if I had $1 for every time the word trust was said today, I'd be very rich. But I'm wondering, in higher education systems, what are we doing to build the trust in those future generations for AI to have to build the systems that are trustworthy and to build the systems that are ethical?
So I like talking, I'll start. I think one of the biggest pieces for trust is transparency. And I know from what we've done within our organization that one of the biggest selling points for any of the AI that we are implementing is its transparency. And we are very purposeful in how we teach the staff that here's where the AI is pulling the information from. You click this, you see where the AI got the information. It is transparency. If it's too hidden, they're not going to trust it. You don't trust murky water, you trust clear water. And the ability for them to see it helps with that trust. And I think that that's going to continue to carry through in almost any AI is the transparency that you have behind it. We've heard it today with the transparency of the data sets, the transparency of where it's getting from, the transparency of how often it's being, going back and somebody is looking at that algorithm. It's the transparency that will help to build the trust.
Hello. Yeah, so from that trust standpoint, governance, especially in healthcare, governance is going to play an important role, right? This governance is going to, especially in healthcare, it's going to come up with explainability on how decisions are being made and transparency on how data is being used, and also bring in how decisions are made. That's all going to be part of governance. Is going to build that trust is the way that I'm seeing.
Do we have a next question?
Yes. My name is Lakedra Salazar. I'm also working at Texas Health, and I'm an informatics student. And we talked a lot today about how AI impacts us in the hospital, our patients, the providers at the bedside. And we also talked about like the outward forces that affect us, like the government and the legislative matters. What do you think about how AI is going, other outward people who impact us directly, being like the big pharma, and then also just insurance companies? How will them using AI, how is that going to impact healthcare? Because we don't only have the government to worry about.
I think for the big corporations like that, it already has, right? So there's a reason CMS has a ruling that says insurance, thou shalt not with AI, okay? Mm-hmm. They're totally on top of it. They have the resources. We just have to, as a society, we have to decide, are we gonna, is it important enough to us to put some regulations in place? But they're already doing it. Yeah, it's not how will it impact them, it's like how will we manage that?
Right.
So, yeah.
And I think from insurance company standpoint, what we have seen is, especially in terms of fraud and waste, there has been AI algorithm put in place where we can predict, right, what are the fraudulent claims and how can we avoid it.
Unfortunately, you can use the AI to commit fraud.
And that's where this...
Weapon. Yes. Yes.
So that is one area. And then prediction, right? Population health is another area where we can predict on, in terms of next year where the spend is going to be. So those are the areas where we see from insurance company standpoint, AI being.
Well, I think this is going to conclude our panel. We're looking at the time, and I think Dr. Ball has to come back. So thank you so much to each and every one of you again, and thank you for coming and being part of this panel. We can take you there when we go down.
One more question. Thank you. That was a great discussion. Where do you see the AIs moving forward? We have so many data centers. Where do you see the aspect of sustainability in this with the health systems and the use of data and AI? Sustainability. Can you hear? Yep. Climate change, health systems, and sustainability and use of AI.
I wish we had a short answer for that. There's not. Okay. I mean, I don't know what else to tell you. That's an ongoing problem that we're just going to have to try to cope with, again, as a society and from the world, from the entire world. There's not a short answer for that. Sorry.
Thank you.
It's an excellent question. There's just not a short answer.
We'll have a conference on that next year.
Thank you.
My first degree was in film. I used to help people with their mics all the time.
Well, it's been a great day. Dr. Ball will close us out here in just a minute. Here's the QR code on the screens as well as on each table for you to complete the survey for contact hours for nursing or for HIMSS. As a quick reminder, to attend 90% of each session you choose and complete and submit the evaluation in order to receive the certificates. The survey will close on Monday, October 6th at 5 p.m. The link in the QR code will also be sent out by email to the email that you registered with. Please allow at least 3 weeks from the date the survey closes for me to get the certificates emailed to you because they're manually done. If you have any questions, there is my email address, and I will now turn it over to Dr. Ball.
Well, everyone, it's come for some closing remarks. So I think we've had an unbelievable time together. So we wrap up this incredible day. I want to thank each of you for being part of the 5th Annual Texas Health Informatics Alliance Conference. Your presence, your insights, and your commitment to advancing trustworthy and responsible AI in healthcare have made today truly inspiring. From thought-provoking keynotes to dynamic panels, lightning talks, and poster sessions, we've seen how innovation is being shaped by collaboration, ethics, and a shared vision for better care. The conversations we've had today are not just timely, they are foundational to the future we're building together. This reminds me of something, particularly after this panel. We are really just at the beginnings of a revolution in our whole field, from a research point of view, from an educational point of view, from every aspect. And it reminds me of something that my father taught me a long time ago when he was very impressed with when Max Planck, who, as you know, completely transformed physics for the world. And when he got his Nobel Prize in Sweden and was coming down from the awarding of this fabulous award, he was asked by the press, Dr. Planck, how in the world did you come about to completely transform the whole world of physics? And his answer is one that we should all learn from. and that was, in the correct formulation of the question lies the key to the answer. And that was his answer to the press. Our panel just now started us all thinking as to how do we go, and what we learned from Albert Einstein, doing the same thing over and over and expecting different outcomes is the definition of insanity. We need to reform our curricula. We need to ask the right questions. We need to see what we can do with the now available tools to transform what we're doing in the next 10 to 20 years. Today was just exciting to see so many questions beginning to be asked. We stand on the shoulders of giants and we can see further. But when we see further, let's see what questions we should ask. So with that, let me also just take a moment and give special thanks to our speakers who really absolutely inspired us today, to the moderators, the exhibitors, and the working group chairs for their leadership and generosity in sharing their expertise. And to our planning committee, conference staff, and volunteers, truly thank you for making this event seamless and absolutely perfect. We look towards seeing you again soon. However, I would like to take just one moment to call out those people behind the scenes who have done so much so quietly, not only today, but over the last, almost from the end of our last conference. I want to particularly call out Jatinga Knox, Catherine Flaherty, Dagan Blood, and Melissa for her wonderful work, Gonzalez, all of whom have quietly, all day to day, made this possible with the food service and the technical people. So thank you all, wherever you are. Have a safe afternoon, have a lovely weekend, and those that are traveling, I hope your flights are on time. Thanks again, see you next year.